Welcome to today's Smart Learning class on RPLND for testicular cancer. And today's program is being conducted by Christian Medical College, Vellore, under the leadership of Dr. Santosh and his team. So I request you that we pay homage to to our colleague who was murdered, and for a minute of silence, and followed by that we'll start the seminar. So yes, I request Dr. Santosh to please introduce all the participants in the webinar and the moderators, and what would be the outline of his talk for tonight, and then we can start. I'll hand over the proceedings to Dr. Santosh.
Thank you, Dr. Sujata. Thank you from the ISU to have given us the opportunity to conduct this teaching session, and also for letting us choose this topic. The main reason for choosing this topic is, one, testicular tumor is quite rare. Second is, most postgraduates in urology are working in centers which do not deal with high volume disease. And the intricacies of management are too complex. The surgeries are not economically viable, and many reasons why these surgeries are not done at most centers. There is a handful of centers which have a big experience of this disease, and I'm really thankful that I work in one of these centers, and we have actually with us seasoned panelists who have a vast experience on this disease. Dr. Ganesh Bakshi, who worked in Tata Memorial in Mumbai and has had a big experience of this disease and is now working in Mumbai. Dr. Amlesh Seth from AIIMS, Delhi, again, a big center with a lot of volume of disease. Dr. Sudhir Rawal from RGCI, again, he's a pioneer in the robotic RPLND. And at the end, Dr. Ganesh Gopalakrishnan from Coimbatore, and he was nearly alone doing most of the RPLNDs during his tenure in Vellore, and he's been always passionate about doing long and big surgeries. And from the team in Vellore, I have Dr. Sukhdev Singh, who's assistant professor, Dr. Madhuri, who's associate professor, Dr. Arun Jacob, who's a professor, and Dr. Santosh Naga, he's associate professor, and Dr. Nirmal John, who also has a keen interest in uro-oncology and be leading the uro-oncology unit at CMC Vellore. So he's the professor and head of unit 3. So we have chosen the topics very carefully because it is meant for postgraduate teaching, and also this is for high-level discussions on specific issues. And most of these things, most postgraduates, I personally feel, do not know. So a lot of time we get carried away in the exams and in the video sessions at looking at the real art of doing the surgery. I personally feel very few, I think not even 1 or 2% of the urologists will actually have to practice the art of doing a RPLND or a good RPLND. For most, we need to understand the science behind it. So you will find that there is absolutely no discussion on the art or technique of how we do, but on the science. And with those few words, I welcome the panelists. Thank Dr. Sujata again. Thank for my team from Vellore. And we will start with the first talk, that is lymphatic drainage of the testis and the anatomical basis of templates for dissection from Dr. Sukhdev Singh. Sukhdev, can you put your slides on?
Yes, sir. Is my screen visible, sir?
Yeah, nice.
Okay.
Full screen start. Thanks.
Okay. So I'll start today's lecture series with the first talk on lymphatic drainage of testis and the anatomical basis of templates of dissection. So, sorry, 1 minute. So we know that RPLND is critical in staging testicular tumors, and for low volume metastatic disease, it is also curative. And the problem with RPLND is it has got high rates of anejaculation. So you need to have a very good knowledge of retroperitoneal anatomy because it enhances cure rates while reducing the surgical complications. So our outline of today's topic will be first, we'll be seeing about the basics of testicular lymphatic drainage, then about the retroperitoneal neurovascular anatomy, and finally about the modified templates and the clinical implications. So this is how RPLND is evolved over time. Before 1900s, it was only radical orchiectomy and plus or minus high excision of cord along with ilioinguinal dissection. It was only after 1900s when all the cadaveric studies about testicular tumors were reported, people started doing a para-aortic and para-cave, that is the classical RPLND. And initially, those were all retroperitoneal, and then from 1902, transperitoneal approaches were started. So these were how the previous incisions looked. Patients used to have large thoracolumbar incisions for an RPLND, which was done extraperitoneally. Patients have to be done on both sides because it's difficult to approach the other side from one side. So about the testicular lymphatic drainage, Donoghue in 1982 had first described the topography of retroperitoneal lymphatics with regard to testicular tumors. So in the intra-hilar zone, you have the paracaval, precaval, intra-aortic cable, pre-aortic and left para-aortic nodes. And in the suprahilar zones, you have the right and left suprahilar zones. Along with it, you have the right gonadal, left gonadal, and the right and left common iliac nodes. So the testicular lymphatics actually starts as small 4 to 8 small trunks from the mediastinum of each testis. Then it ascends along the cord, along the spermatic vessels. And at the crossing of the ureter with the spermatic rods, they unite to form the small lumbar trunks, which finally drain into the cisterna chyli, which is a small sac-like structure which lies in front of the L2 vertebra. Then it eventually drains into the thoracic duct. So now about the landing zones, we know that germ cell tumors exhibit predictable lymphatic drainage with the exception of choriocarcinoma. So all the early evidence about landing zones were from cadavers and lymphangiograms. It is only after 1955 from when Ray and Whitmore and Donoghue had described testicular landing zones when they had done full proper infrahilar and suprahilar RPLNDs in testicular tumor live patients. So this was Donoghue's publication in 1982 from Indiana University, where he had done full bilateral extended infrahilar and suprahilar dissection in 275 patients with testicular tumors. And from those patients, he had reported that for right-sided tumors, the most common node which were involved were the inter-aortic cable, followed by the precable, followed by the pre-aortic nodes. So this is logically because the right gonadal vein drains into the IVC, unlike the left side. So the most common landing zone would be the inter-aortic cable or the precable. So similarly on the left side, because the left gonadal vein drains into the left renal vein and not the IVC, the most common landing zone would logically be the para-aortic, followed by the pre-aortic and the intra-aortic cable nodes. From all these studies, Donoghue and Ray and Whitmore had concluded that if ipsilateral nodes were negative, the chances of contralateral nodes being positive is close to zero. And you can omit a suprahilar lymphatic dissection if it's particularly a low-stage testicular tumor. And also this paved way for modified templates. For example, for left-sided tumors, you can omit suprahilar zones, right paracable and right iliac nodes. And similarly, for right-sided tumors, you can omit the suprahilar zones, left para-aortic and left iliac nodes. And intra-aortic cable zone is to be considered a common zone for both right and left-sided testicular tumors. So now we are seeing about the lymphatic drainage. We'll move on to the vascular anatomy. So apart from the major vessels like the aorta and IVC, we see in the retroperitoneum. The most common vessels we encounter and are a bit scary are the lumbar vessels. So the lumbar arteries are usually paired and are very uniformly spaced, unlike the lumbar veins, which are unpaired, they variably spaced and they drain into the left posterior side of the IVC. Oh, this is there are various vessels, but in 2016, Beveridge had done a cadaveric study where he had clubbed all these vessels into 3 groups called superior, middle, and inferior vessels. So this is a good roadmap for identifying the vessels. For example, in the superior group, if you identify the right gonadal vein, you can identify the second pair of lumbar arteries in the right superior lumbar vein, which almost lie in the same level. Similarly, in the middle vessels also, if you identify the inferior mesenteric artery, you can identify the third pair of lumbar arteries in the common lumbar trunk, which almost lie close together. Similarly, in the inferior group also, when you identify the fourth lumbar artery pair, you can identify the right and left inferior lumbar veins. So now about the neuroanatomy of retroperitoneum. So this is a basic scheme of how the retroperitoneal neural network lies. So the nerves concerned with our RPLND are the lumbar splanchnic nerves and the superior hypogastric plexus. So this is a general scheme, but it does not appear so in a live RPLND. This is how it looks among how the nodes lie among an plexus of nerves. So to simplify and to identify all the nerves, so the most important ones are the first and second lumbar splanchnic nerves. So the first lumbar splanchnic nerve on the right side is closely related to the right superior lumbar vein. Similarly, on the left side, the left first lumbar splanchnic nerve is just anterior to the left lumbar vein, which drains into the left renal vein. And inferiorly, the second lumbar splanchnic nerves on both sides are commonly related to the common lumbar trunk, which is related posterior to the second lumbar splanchnic nerves. So these are how the templates look like. The retroperitoneum looks like when you have ligated the lumbar vessels. So now the IBC has been looped above. Now you have identified the dorsal sympathetic trunk from where you trace the preganglionic nerves which travel anteriorly into the anterior surface of aorta, where they join to form the pre-aortic plexus, which then become the pre-aortic plexus and finally the superior hypogastric plexus. So now finally about the templates after seeing the neurovascular anatomy. So when we do a bilateral RPLND without sparing any of the nerves, you will invariably cause an ejaculation in almost all patients. So you need to weigh the pros and cons. First is you need to reduce relapse, but at the same time you need to preserve the antegrade ejaculation. So there are two ways to preserve ejaculation. One is you do a full bilateral infrahilar RPLND and carefully and meticulously dissecting each and every nerve, which is going to be tedious. Second one is a modified template where you can reduce the margins of a classical bilateral infrahilar RPLND. So modified templates, as we had seen earlier, was from the periods of Ray and Whitmore and Donoghue from 1955. There are various modified templates, but the common theme among all the templates are you resect the ipsilateral nodes till the common iliac bifurcation, but on the contralateral side, you stay above the inferior mesenteric artery. So the concern for doing a modified template is basically you're reducing the margin of the template. So you are likely to have an extra template disease, which depends on the setting, whether it's a primary or post chemotherapy. The histology varies. So these are how the full classical template in the right and left modified templates appear. So there are no head-on comparisons between a radical and modified RPLND, except one publication from 1990 from Germany, which they had compared radical and a modified RPLND. So the relapse rates between radical and modified RPLND were almost similar, but the antegrade ejaculation was significantly better when with patients having a modified RPLND. So these are the various templates currently practiced across the world. So among the open templates, you have the testicular tumor study group from the Germany. Next, you have the Indiana University. Then you have the MSKCC template, which is the most elaborate among them. And among the laparoscopic templates, you have the Innsbruck and the Johns Hopkins University templates. So as we had seen earlier, the very important concern among from when you are doing a modified template is you are prone to have an extra template disease. But the problem is it differs between different settings. So the most common setting now we do in RPLND is in a post-chemotherapy setting. So in a primary RPLND and a post-chemotherapy RPLND, the chances of having an extra template disease is going to be less than 30%, but the histology is going to be different. In a primary RPLND, the chances of the extra template disease being a viable malignancy is almost 90%. But in the post-chemotherapy setting, the chances of the extratemplate disease being viable malignancy is only less than 25%, and it is most likely a teratoma. So because you've done an RPLND in a post-chemotherapy setting, and if you leave an extratemplate disease, which is going to be teratoma, and we know that teratomas are going to be chemo and radio resistant, the only way you're going to treat it is with the repeat RPLND, or if you leave them alone, it's going to become a growing teratoma. So finally, to conclude my topic, for a primary RPLND, modified templates are the current standard for low-stage testicular tumors. In case you find positive nodes intraperitoneally, switch to a bilateral RPLND. But in a post-chemotherapy setting, full bilateral infrahilar RPLND is the current standard, with modified templates to be done only in highly select patients in very high volume centers. Thank you.
Thank you, Dr. Sukhdev. You can stop sharing your presentation. Now I call upon Dr. Madhuri. She is associate professor and a very keen interest in neuro-oncology, and she is doing quite a lot of volume of work of these difficult surgeries. And she'll be talking on the pre-operative, intraoperative, and post-operative care of patients who are undergoing RPLND. I have realized that since this volume is quite less, most postgraduates are not aware about the nuances of these preparation of these patients and managing them. So I have requested Madhuri to take this important topic. Over to you, Madhuri.
Thank you, sir. This actually happens to be one of my favorite topics, perioperative management of various operations, especially major surgeries. So thank you so much for giving me this topic. So the topic that was given to me was preoperative, intraoperative, and postoperative, but I'm just encapsulating everything because all of them are interconnected. So going on to my next slide. So these are my learning objectives for today. We're going to go through these headings. So the way that a patient can recover largely depends on many factors. It depends on what kind of an RPLND that he has had. Dr. Sukhdev has gone over various types of RPLNDs. The one that is quite favorite and very easy to remember is this one. It's called Indiana classification. And these are the subsets. A standard RPLND is a person who's undergoing a primary RPLND, and a complicated RPLND is a person who is undergoing procedure after if they've not responded to chemotherapy with first line of chemotherapy. It also depends on what kind of chemotherapy that they have, what comorbidities they have. Was it an open surgery, laparoscopic, or was it a robotic procedure? Was it a transperitoneal procedure? Was it a retroperitoneal procedure? And what the extent of the disease is, and the extent of the templates. So going on, just before I go on, I just wanted to go on about how chemotherapy affects the recovery of RPLND and why it is important to know this, because each of these chemotherapeutic drugs affects the patient systemically. For example, bleomycin-induced pulmonary fibrosis is very common. It affects up to 10% of patients who have had chemotherapy with bleomycin. And risk factors of developing this is patients who've had high doses of bleomycin, patients who have pre-existing renal function that is impaired, and patients who are smokers and who are a little bit older than the regular population. And the way to counter it, and this is very important, and this is the core treatment mechanism that we use, is to restrict oxygen and to restrict fluids during the surgery. Another drug that is used in BEP is cisplatin, and the cardiotoxicity is very, very common in these patients. They develop hypertension, high risk for DVT. About 6% of these patients can develop cardiac events and have ventricular tachyarrhythmias. And other common things that we know about is already nephrotoxicity, peripheral neuropathy, and autotoxicity. Etoposide myelosuppression is something that can happen because of etoposide, but usually by the time they complete chemotherapy, it is not so much an issue, because of which we have to be careful about what kind of preoperative investigations we do for these patients. So if a patient has anemia, it's important that we correct it before the procedure, and if necessary, we must give them parenteral iron so that they have decent hemoglobin levels before the surgery. Each of these investigations have to be done at least a couple of weeks before the surgery. They should have achieved normal WBC and platelet counts, which means that they should not be myelosuppressed anymore. And these are regular investigations that we do, that is liver function test, renal function test, pulmonary function test on account of having bleomycin in the chemotherapy. And to rule out cardiotoxicity, we must do ECG, echo, and TMT. Many times what happens is these patients are not perfectly optimized, but we have to send them to respective specialties like cardiology and pulmonology so that they can be optimized to the best state possible before the surgery. Another thing that we must do is staging procedures with CT, thorax, abdomen, pelvis, and tumor markers within 6 to 8 weeks after receiving the last chemotherapy. And MRI should be done if you're suspecting vascular involvement. So from then on, we go on to informed consent. I believe that informed consent should start not at the time just before the day of surgery. It must start when you have a patient who's come to you with, say, stage 2 or stage 3 disease, who will probably require post-chemotherapy RPLND after his chemotherapy. So you're going to have to start talking about this right from the beginning, because the patient and the family are mentally prepared for this kind of major procedure. So like Dr. Sukhdev said, if your nerve sparing procedure is possible, that is usually done in modified or in unilateral modified template or in a primary setting, then 90% of the time you may preserve ejaculation, but you should assure them that usually erections are not an issue. And in these kinds of patients, ideally they should have had cryopreservations of semen before the chemotherapy, but if it is not done after the before the chemotherapy, you might still get away by doing it before the surgery. Another thing that you should talk about is adjacent organ injury. We did a study recently, which was published in IJU, and our findings were that nephrectomy was necessary in about 6% of patients, and small bowel injuries, especially duodenal injuries, were common in about 5% of patients, and all other complications with respect to adjacent organs only occurred in less than 2%. However, in other large cohorts in the Western countries where they do higher volumes, they find that vascular injuries and vascular aortic grafts and venous grafts are more common. So this is something that you have to talk to them about. A good way of trying to illustrate to the patient about what they might be in for is by showing them a diagram like this. This is an excerpt that I've taken from the POS consent form, and something like this is easy for the patient to assimilate. So this is what I'd like to talk about next is called prehabilitation. The 4 pillars of prehabilitation is nutrition, chest, ambulation, and psychological prehabilitation. Like I said earlier, it's about preparing the patient several weeks ahead. So we're just going to go through these one by one. In the nutritional aspect, what we do in our institution, and I recommend that everybody does this for any kind of major surgery, is to send the patient to a dietitian who is going to assess what kind of catabolic state the patient is under and give them supplements with multivitamins or high protein diet, and whether they're depending on whether they're vegetarian or non-vegetarian, give them proper advice on how to improve on their diet. Studies have shown that giving a high protein diet even 2 weeks before the surgery can improve their nutritional status. Next is early ambulation. This must be reiterated before the surgery because you have to tell them that you're going to have a very long incision if it's an open procedure. Post-operatively, you will have an epidural and you're going to be expected to walk. And this kind of conditioning is very important for the patient because patient is under the impression that they have a major surgery and they don't usually move. So telling them preoperatively that they are going to be expected to do this is very useful for them psychologically. There are some experimental studies that have shown that training, exercising, like improving your conditioning during chemotherapy might actually prepare you for a major surgery like the RPLND, but this is just under experimental phase right now. We've already spoken about chest because of bleomycin and otherwise also. These patients, because of their very long laparotomy, they can have diaphragmatic splinting and the effects of bleomycin. So they must go to the pulmonologist to have a pulmonary medicine assessment with the pulmonary function test if necessary. You should also go to the physiotherapist so the physiotherapist can teach them about incentive spirometry and deep breathing. And if they're smokers, you must advise them to quit smoking at least 4 to 6 weeks before the procedure. And psychologically, telling the patient all of this is very important, and that prepares the patient and their family as to what they're going to get into. The day before the surgery, bowel preparation is just low residue diet, liquid diet for up to 24 hours. And they're allowed clear fluids up to 2 hours before surgery. And that is common for all major surgeries or any surgery for that matter. About 1 to 3% of these patients can develop DVT, hence you must give them DVT prophylaxis with mechanical thromboprophylaxis, that is DVT stockings. Knee length should be all right. And then you can give them low molecular weight heparin just about 12 hours before the procedure. Or if the patient has any sort of renal dysfunction, then unfractionated heparin will be more appropriate. You must cross-match at least 3 to 4 unit pack cells. And if you think that the procedure might be more complicated, like if they have large tumor burden that is encircling major vessels, then you must also cross-match for cryoprecipitates and FFPs. Once the patient is on table, these are the lines that we usually put. Invasive monitoring will include arterial line, subclavian line, a rapid infusion cannula, a small, short, wide gauge cannulas that you can use per urethral catheterization to monitor unit output, a temperature probe, A hot dog is a device, it's a flat heating mattress that is placed under the patient, and there are several other devices like that. You can have that. Fluid warmers are used so that IV fluids are warm as they go in. And even intraoperatively, when you are operating, you must require the scrub floor nurse to get you warm fluids, warm saline when necessary. Intermittent pneumatic compression is to prevent DVT intraoperatively. An NG tube is placed in situ, and once the laparotomy is done, the surgeon is supposed to check if the NG tube is in situ. And positioning must be done so that all the joints and all the organs, all the hard parts of the body, like the ankles and the heels, are well padded. So to manage pain, intrathecal opioids can be given in the form of epidural catheters. Rectus sheath catheters is something that people are using abroad. It is not so common. Even in our center, we don't do it, but it's something that we can explore. I'm going to show you a picture of that in a minute. Patient control analgesia is also another method where patient can use their own by themselves. They have an intermittent periodically, they can infuse themselves with an opioid. So this is just an illustration of a picture of a patient who is prepared for an RPLND. Over here, they have some soft gel pads, and all the bony prominences are well supported so that there is no chance of ulceration. Each of these operations are about 6 to 7 hours, 4 to 6 hours, depending on the extent of the procedure. So it's important to keep this in mind. This is a picture of a rectus sheath catheter. This is actually placed by the surgeon. An epidural-like catheter or a scalpel vein like needle is placed in the posterior rectus sheath, and this is continuously connected to an infusion set where you can put in long-acting, medium to long-acting bupivacaine. So oxygenation, if you can remember what I said about bleomycin, oxygen restriction is important in these situations. Patient develop restrictive pulmonary disease. So reducing oxygen apparently is very useful for these patients. You must keep the oxygen at about 30% FiO2 so that they can maintain a PaO2 of 60. Normal is more than 70. So just about 60 is also enough. So a saturation reading of 92% is more than enough. Unless the patient is really hypooxygenating, it is not necessary to go over 30%. Fluid management, for the same reason why oxygen restriction is useful, fluid management is also necessary by reducing it. You have to keep monitoring this by monitoring the heart rate and some of the things like systolic blood pressure and pulse pressure variability. It's really important to do this again to avoid ARDS. Blood loss of about 500 ml is average is expected, but it can go up to massive transfusion protocols because we are operating around the great vessels and important named vessels. In these kinds of situations, abroad cell savers are not really used because it's not recommended in oncological surgery. Tranexamic acid is also avoided because bleomycin causing DVT, animal studies have showed that bleomycin can cause DVT by interacting with tranexamic acid, and therefore it is better if you don't use it. Post-operative management, patients usually we do not use drain. It's better to monitor these patients in an HTU or an ICU setting. So you can remove the NG tube the next day or the day after, depending on what the patient's ILS status is. Removal of catheter and epidural usually will take place at around 72 hours. IV fluids should be regulated depending on how much IV fluids the patient received intraoperatively. Oral alimentation is usually started just the next day itself or the same day, even with sips of fluids, and you have to pause and delay it if the ILS is setting in longer than usual. You have to start ambulating the next day itself, and DVT prophylaxis is continued till at least day of discharge, if not up to 4 weeks, which is usually recommended according to guidelines. And amongst all the outcomes that I've talked about, practically these are outcomes that we usually come across, which is tachycardia, because we're operating around the sympathetics. There's usually sympathetic hyperactivity that causes tachycardia. And the team that is looking after the patient should be rest assured that that's a differential and it is not something else like a septicemia or blood loss. Prolonged paralytic iris is something that is very common and should be managed accordingly. Sometimes it may be transient hyperamylasemia depending on because of the retroperitoneal dissection. And atelectasis is another common thing which can be easily prevented or managed efficiently by looking after by doing the prehabilitation. An acute kidney injury can also occur because of the fluid challenges and because of his preoperative chemostatus and other factors such as that. So conclusion, putting all of this together, I think we can come to a safe conclusion that these kinds of operations should be done in high volume centers where there is multi-specialty support and where there is ISU support. Thank you.
Thank you, Madhuri, for that elaborate presentation. Because of lack of time, I think we'll take all the questions in the end. And I'll call upon Dr. Arun Jacob Philip George, who's a professor, and he'll be talking on RPLND in cases of seminoma. Thanks, Madhuri. Arun, you can share your presentation.
Just coming on. Is it visible now?
Double click. Yeah, we can see it's still not in full screen.
Yeah, going to. Done actually.
Yeah, we can see it full screen now. Start.
Yeah, good evening, distinguished panelists, my teachers, colleagues, those logged in now and those who are going to log in later just before the exam. This presentation will have quite a lot of information that you can keep for reference later. Management of the retroperitoneum in seminoma is well established as in non-seminoma, or is it? In stage 1 seminoma, for example, there's still some controversy as to which treatment option to adopt. Or rather, I say there's no particular gold standard. Is it radiotherapy, single agent carboplatin, or RPLND? So in today's talk on RPLND in seminoma, I'm going to divide it into mainly two, the primary RPLND and the post-chemo in seminoma. The reason for staging, which I'm not going to talk about, is to know what option to choose for the retroperitoneum, whether it's radiotherapy, chemotherapy, or RPLND, all of which have been done before in the past. Observation being also an option in stage 1. We will talk about the rationale for primary RPLND, which is coming back into vogue now, especially with the newer options of treatment like the robotic, where there'll be a lot of people willing to go back to what was done many years ago. And the second part will be regarding the post-chemotherapy residual mass. As in many other things, there's also a trifecta for contemporary management of germ cell tumors. Oncological efficiency, for sure, mitigation of treatment-related morbidity, and improvement of long-term survivorship. What are the established managements? For example, in seminoma, and I'm talking about 2A and B now, chemotherapy, radiotherapy, but the challenges, of course, are of the cardiovascular, other toxicities, and long-term risks which exist and have been established. Hence the rationale for RPLND in seminoma, and that to the primary RPLND. Why is it attractive? Because of the surgery's well-established efficacy. Predictable pattern of nodal lymphatic spread. And seminoma, pure seminoma, will never have choriocarcinoma, which is the only one which will have a hematological spread. Urologists who are treating testicular cancer are already familiar with the procedure if they've been doing it. Template dissections, nerve-sparing approaches have been spoken about by Sukhdev. And newer techniques, laparoscopy, midline extraperitoneal approaches, the advent of robotic surgery does minimize morbidity and encourage a lot of the newer surgeons to want to go back to RPLND. Looking at the evidence, that's what I'm going to be talking about. RPLND was practiced before. We have 3 retrospective studies, which is presented in a review article by Ganesh in 2018. And very good results with 0 recurrence rate, for example, in even stage 1 and stage 2. Taken together, very few recurrences happened in field. The overall recurrences may have been outside the retroperitoneum. But there were 2 prospective trials which need mention and which will be important to write in the exams. The SEMS, surgery in early metastatic seminoma, the PRIME test, and then there's a co-TRIMS shall come to. There were phase 2 trials, accruals are over. Data has been published in 2023. One is a multi-institutional, which is a SEMS, and the other was single institute. The PRIME test did include patients who had a single agent carboplatin also, so it was not a pure primary RPLND. Specifically going to the SEMS, for which you might get a short note. Surgery in early metastatic seminoma was a phase 2 trial. Of all the patients who experienced recurrence, 10 were treated with chemotherapy, 2 underwent additional surgery. And at last follow-up, all patients who experienced a recurrence were disease-free. 2-year overall survival was 100%, which is brilliant. 4 patients did experience some short-term complications. And the median follow-up that they had overall was around 33 months, which is good. If you look at the Kaplan-Meier of the survival after RPLND, the 2-year follow-up has been completed. It's really good. Nobody particularly was off. The grid, in fact, if you look at the number there, the number at risk, which is what is written at the bottom, comes down to 1 even at 5 years. 2-year survival being 100%. When they stratified this and got the Kaplan-Meier for clinical node versus pathological node, because all of them had surgery, even then the recurrence-free survivals were really good. And the node-wise distribution is mentioned. What are the variables associated with the recurrence? Patients who had imaging done more than 4 weeks before RPLND had a higher recurrence rate compared with those who had a recent imaging. And not significantly associated with recurrence were bilateral versus modified template, serum tumor marker elevation, pre-op versus normal tumor markers. We also look quickly at the PRIME test study, where I said the trial also included patients with recurrence after a single dose carboplatin, other than the primary RPLND group itself. And they also had a good recurrence-free survival, though not up to 100% as quoted by the SEMS. There was also the co-TRIMS trial, where Heidenreich et al. Reported a relapse rate of only 9.5%. But we're talking about smaller numbers. Again, at a median follow-up of 20 months. Now, taken together, these studies, the SEMS, the PRIME test, and co-TRIMS, demonstrate that RPLND has significant disease-free survival rates and eliminates the need for chemotherapy in the majority of the patients, and hence eliminates the need for or takes away the risks which are associated with chemotherapy long-term. But RPLND does have its own limitations, ejaculatory issues, hernias, bowel obstruction, and all the short-term problems The most worrying of these probably being the thromboembolism because of a long surgery, chylous ascites, injury to surrounding structures. The other advantage of doing the RPLND is there's pathology available. In fact, there were times when in their study, there was pathological downstaging from clinical stage, nodal stage to pathological node negative, which meant less rigorous surveillance. If there was same pathology as in clinical stage, surveillance was still considered an option. And if there was upstaging, chemotherapy could be offered. The proponents of chemotherapy, on the other hand, especially the Getter-Simitep study, say that de-escalating chemotherapy in good prognosis seminoma based on the FDG PET is an option. So mitigating all the long-term side effects. There's also the SAC 01/10 trial, which talked about chemotherapy and no in-field recurrences, all at remote sites. So the argument for chemotherapy being primary chemotherapy is the current standard, and because of the unique chemosensitivity, reducing the dose seems to be possible. And they argue that even though RPLND in some study has claimed 100% recurrence-free survival, there is a relapse which is recorded in other studies and so should only be regarded as an option. Now, the second part of my talk is going to be on the post-chemotherapy residual mass management in seminoma. Now, we all know RPLND as such is a tedious surgery requiring a lot of patience. RPLND in post-chemotherapy residual mass of seminomas is a nightmare, to say the least, because of the dense desmoplasia and the reactions difficult to find planes. The therapeutic options currently still include surveillance, depending on the size of the mass, could offer radiotherapy, and RPLND. Now, in residual masses more than 3 centimeters, there is again controversy on the optimal approach. Some recommend surveillance for all the post-chemotherapy masses, irrespective of size, as and when it may reduce. Others recommend RPLND for all masses. The rationale being 20-30 masses may have some viable tumor, even though we talk about 90 and 10 as a percentage. The challenge is the desmoplasia and higher morbidity, worsening quality of life. Complete resection, therefore, is only possible in a few patients. Coming to the SEM-PET trial, which is the one which claimed that based on the FDG PET, there was a very high positive predictive value, claiming up to 100%. End of treatment, more than 3 centimeter mass, PET CT had a negative predictive value very high of 96 and a positive predictive value of 100%. Though other centers weren't able to replicate this, PET CT became the tool to guide decision making for any mass more than 3 centimeters. Non-avid masses more than 3 centimeters were kept on follow-up. DeSantis and all initially wrote about this in 2001, published in 2004. And to look at just the figures and the comparisons, other studies had also done it. It is only DeSantis' SEM-PET study which talked about 100% positive predictive value, 197% negative predictive value. In our own study, with a smaller number of patients, albeit, we weren't able to achieve the same positive predictive value, though the negative predictive value was high. There's an interesting way to look at this too. DeSantis had these small numbers, if you look at this 2x2 column, with no relapse, 1 false negative, and our calculations, TN is for true negative, FP is for false positive, shows with such small numbers, it is possible to generate 100% and 96%, something to just think of when we see these extreme values. Thank you.
Thank you very much, Arun. Thank you for emphasizing on the fact that not to take the SEMPET study at the face value and the problems with doing a RPLND in post-chemotherapy, residual masses and seminoma. Now I call upon Dr. Santosh Naga, who will be speaking on RPLND in NSGCT. Over to you, Santosh. He's Associate Professor and soon to be Professor. Come on, Santosh.
Can you see the slide and hear me, sir?
Yeah, we can see. Carry on.
Thanks. Good evening, all of you. I'll be speaking on RPLND in NSGCT. Retroperitoneal lymph node dissection forms a important part of the algorithm in the management of NSGCT. This will be the broad outline of my talks. Some of the concepts may be a repetition based on the previous talks, but I'll try to reinforce some key aspects. I also have a few short video clips. I guess bad idea with a Zoom webinar, but hopefully my luck works today. Very quickly about the introduction, germ cell tumors constitute about 95% of all testicular cancers. And as we know, we're dealing with a very young patient cohort, most of them being between 20 and 30 years of age. So with a multidisciplinary team approach, we can aim for excellent oncological and clinical outcomes. So according to the WHO updated classification, the non-seminomatous tumors come under the germ cell tumors derived from the germ cell neoplasia in C2 category. And this constitutes about 40 to 45% of all the germ cell tumors. So we're dealing with a big chunk of patients. And very quickly about the staging, just to brush up before we go on to the management. The T1 includes tumor limited to the testis, T2, 3, 4 being locally advanced, while the N1, N2, N3 would be lymph nodes less than 2 centimeters, 2 to 5 and more than 5 centimeters, and M would be the Mets. And accordingly, the stages would be stage 1, which is just limited to the testis. Stage 2 would be with lymph node positivity. And stage 3 would be metastatic. And as we know, testicular tumor is unique in the sense the tumor markers are a part of the classification, the post-orchidectomy tumor markers. So the types of RPLND, just like Arun has already spoken about, it's either primary or post-chemotherapy. Primary, as the name suggests, is upfront retroperitoneal lymph node dissection in clinical stage 1 and select stage 2 patients who've not had any other form of treatment with normal tumor markers. While post-chemotherapy RPLND can either be a standard post-chemotherapy, where after a standard course of post-chemotherapy, the residual mass is dealt with as a retroperitoneal lymph node dissection, or as Madhuri touched upon, as per the Indiana classification, it can be a complicated post-chemotherapy retroperitoneal lymph node dissection, which includes salvage, which is after induction and salvage chemo, or desperation, which is performed despite having high tumor markers, which is suggestive of tumor being chemo-resistant, or in-field recurrence after a primary or a post-chemotherapy RPLND, or a relapse, late relapse, which is after 24 months of primary treatment. So what's the rationale of primary RPLND? Some of the points have been already alluded in the previous talk. About 30% of clinical stage 1 NSGCT can have occult metastasis. And like any argument for surgery first versus chemotherapy, surgery is only the reliable method to detect the micrometastasis, and also it selects those who may benefit from chemotherapy. And it has a potential for better nerve sparing before the post-chemotherapy fibrosis sets in, thereby potentially having better future successful pregnancies. And as compared to the alternatives of surveillance and chemotherapy, it involves lesser intense surveillance protocols and hence lesser radiation exposure. However, there are a few indicators and variables which can predict the degree of metastasis. And among many available variables, the one that has shown to be having a better predictive value is the lymphovascular invasion and the presence of embryonal carcinoma. And historical series have shown that with presence of lymphovascular invasion, the risk of relapse at 5 years can be as high up to 50%. So in the presence of these markers of risk factors for occult metastasis, and also with the alternative options having good cancer-specific survival and low relapse with chemotherapy, together with the fact that the primary RPLND with good functional outcomes has a low reproducibility on a larger scale, the primary RPLND, the adoption of it on a widespread basis is largely restricted to the American centers. However, it still has a role in clinical stage 1 and stage 2 patients who are not willing or not suitable for chemo or have a poor compliance to surveillance with mainly a teratomatous or a somatic component. And in terms of evidence in this space, there is very limited high quality evidence. This is probably the only available RCT from a German group comparing primary RPLND and chemotherapy and clinical stage 1 NSGCT. They looked at about 350 patients comparing primary RPLND and 1 cycle of BEP chemotherapy. And at a median follow-up of 4.7 years proved that chemo was superior, both in terms of the number of recurrences and the recurrence-free survival. However, critiques of this studies point out that even though this was a multi-institutional study, many centers contributed very few patients, thereby indicating the quality of the retroperitoneal lymph node dissection in these centers would have likely been poor, as indicated also by the relapses, which were 7 retroperitoneal relapses and 2 scrotal relapses, which are probably surgical, as compared to 4 systemic relapses, which when you compare directly with the 2 in the chemo arm may be comparable. So it is debatable in terms of evidence, but however, because this is an RCT, this is a part of guidelines, and this has further taken the primary RPLND away from practice in many of the centers because it's in the guidelines. Moving on to post-chemotherapy RPLND, less controversial. It's indicated in post-chemotherapy residual masses of more than 1 centimeter with normal or normalizing tumor markers. The rationale being, in about 60% of the patients, there can still be a teratoma or a viable tumor. And teratoma, as we know, is chemo-resistant. And as Sukhdev had mentioned, if they're not treated, they can lead to growing teratoma syndrome and also have the possibility of malignant transformation to other histological subtypes. And post-chemotherapy RPLND has a good oncological outcomes with good overall survival, cancer-specific survival, and recurrence-free survival. Principles again has been touched upon. In post-chemotherapy setting, bilateral RPLND is the standard of care, and whenever possible, nerve sparing should be attempted. In highly selected patients, a modified template may be used, and the aim should be to remove all the residual disease and the lymph nodes and not mere resection of the lumps or the residual mass. This has again been shown. There is a lot of debate about the extent and the modification of templates, but the standard bilateral template would have the bilateral ureters as the lateral boundaries, the renal hilum as the superior boundary, and the bifurcation of the common iliac where the ureter crosses as the inferior boundary, including the ipsilateral gonadal vein excision at the deep vein. And the essence of modified template, even though the boundaries and the perimeters may vary, is that, like Sukhdev had mentioned, the aim is to preserve antegrade ejaculation as much as possible by preserving the hypergastric plexus below the inferior mesenteric artery, at least on the unaffected side. However, large series, both of these from the MSKCC series, more than 500 patients studied, showed, like Sukhdev had mentioned, a significant amount, up to 30% of extra template disease, hence not in favor of modified template RPLNDs. However, a more contemporary series published in 2021 from the Swedish and Norwegian well-maintained testicular registry, cancer registry, showed that 65% of the patients actually had unilateral retroperitoneal metastasis on CT scans and a low risk of contralateral teratoma cancer, only 1.6% for the right side and 2.6% for the left side, and low retroperitoneal recurrence. They looked at about 215 patients at a good follow-up of about 100 months median follow-up, suggesting that even in the post-chemotherapy setting, there may be a role in the current era with better CT scans and better imaging. However, the template still remains a debate in the post-chemotherapy RPLND setting. And at present, bilateral standard dissection should be considered the standard of care. Just to show that the aim is to preserve the nerves, either the template or nerve sparing. The aim is to preserve the postganglionic nerves with the hope of preserving antegrade ejaculation. As you can see here, the postganglionic nerves are dissected in this robotic RPLND. This can be possible even by meticulous open RPLND in high volume centers, as can be seen in this illustration. On the left side, hypogastric plexus and the sympathetic trunks have been looped. And on the right side, the para-aortic region is shown, showing the sympathetic ganglion and the nerve fibers. Especially, they lie close to where the lumbar arteries enter posteriorly. As we've seen, the approaches can be open or minimally invasive. This is the study which Sukhdev has already shown. It's an elegant cadaveric study of about 25 cadaveric dissections published in 2017. Just to reinforce key points, for the paracaval and interaortic caval part, the lumbar veins and the lumbar arteries have to be meticulously dissected. Only then the vein IVC can be lifted off to get access to the retrocaval area. As he had mentioned, the lumbar arteries are more predictable. They're about 3 to 4 pairs as compared to the lumbar veins, which may not be paired. And the lumbar veins can also have variable distribution in terms of branching and tributaries, which may cause bothersome bleeding. In terms of the interaortocaval region, the postganglionic fibers usually run posterolateral to the IVC and anterior to the aorta. So usually the split and roll technique is started from the IVC rather than from the aorta. And it has been shown in studies that the para-aortic area is the highest site of residual tumor or recurrence or relapse later, maybe because of the challenging anatomy of the hilum and the lumbar vein, and also the right to left drainage of the lymph nodes. So careful dissection has to be performed to remove all the tumor. And as it's clearly been mentioned, nerve sparing should never be performed at the cost of leaving the residual tumor. Just briefly about the steps of open RPLND. After opening the root of mesentery, the bowel has to be put in warm, moist mops in the chest. Care has to be taken because, as has been mentioned, the length of procedure, you're expecting a long procedure, and the retraction should not impinge on the superior mesenteric artery, pancreas, or the duodenum, all of which are vital structures, and they have to be periodically inspected. And the dissection itself starts with the split and roll technique, like I mentioned, from the IVC, preferably first. And the third image shows the right gonadal vein being tied off, then the interaortocaval packet being dissected, and then proceeding to the pre-aortic and then the para-aortic, where the nerve fibers have been separately looped. Very briefly about robotic RPLND. There have been a few series in the past who had described a flank position, but most of the present series would be a supine with steep Trendelenburg. This would be the operative theater setup where the assistant sits in the lower part, and this is the usual port placement. Just the key steps. In robotic RPLND, the stitches are taken to create a hammock of the retroperitoneum and the bowel, which can then be dynamically tightened to get adequate exposure to the retroperitoneum.
The sutures are tensioned appropriately to facilitate exposure to the retroperitoneum.
In terms of the actual dissection and the boundaries itself, it's very similar to the open RPLND where we replicate the steps.
Until the renal hilum is identified. Here we identified the left renal vein.
Similarly, like I said, the steps are, we try to replicate the open steps. Here it's the split and roll of the IVC. And in terms of the interaortocaval packet, the lumbar veins can be controlled either by using vessel sealers like here or by using clips.
We utilize a robotic vessel sealer to help control the lumbar vessels.
And
care
then
must be taken during this step respectively.
And lastly, the para-aortic packet. And that's how the final dissection would look with the lumbar, with the renal vein above and the para-aortic packet. So as it's been touched by Madhuri, RPLND is a very formidable procedure with with potential for complications. Intraoperatively, we can have major vascular injury and intraperitoneal major organ injury, and left nephrectomy is the commonest adjunct procedure. And postoperatively, these complications can arise. The mortality rate from large series ranges from 0.27 to 0.48, and Clavin window 3 or above complications is marginally higher for post-chemotherapy RPLND than the primary RPLND. These are some reviews showing the same. These include both post-chemotherapy and primary RPLND, with the Clavin window complication ranging from 15 to 30%. And these are a few studies showing the feasibility of robotic RPLND, small numbers, but showing the feasibility both in the primary and post-chemotherapy setting with good antegrade ejaculation rates and acceptable complication rates. As Madhuri mentioned, we published this recently in the Indian Journal of Urology. We looked at 73 patients, all of whom had post-chemotherapy RPLND with a median follow-up of 26 months. In our series, 85% size reduction predicted necrosis, and also our rate of Clavin window 3 complications of 17.8 with good oncological outcomes. Just to summarize, in the guidelines, both EAU and AUA suggest there is a role for primary RPLND in stage 1 and selected stage 2. However, the ESMO guidelines says it's generally not recommended, mainly based on the German study. However, for post-chemotherapy masses with axial diameter more than 1, post-chemotherapy RPLND is standard of care. To conclude, RPLND is an integral part in the management of NSGCT, and regardless of approach, oncological principles should be adhered to, and nerve sparing with functional outcomes should be aimed at whenever possible. And with multidisciplinary approach, good oncological outcomes can be achieved. I'll just leave you with these thoughts, two stalwarts of RPLND. John Donoghue said that the best chance for surgical cure is usually the first chance. And in many of these cases, there was not, it was because the residual tumor or relapse was because of the relative lack of RPLND experience and or the resolve at the time of initial procedure, underlining the importance of high volume surgeons and high volume centers. Same thing was echoed by Shenfield, with whom Dr. Nirmal worked, the person who will be speaking next. Who said that it's not about the ones and twos, but when you get a chance, you have to hit it out of the park with RPLND. Thank you.
Thank you, Santosh Naga, for that exhaustive presentation and a brave way to show the videos which actually work. Thanks for sharing. Now, I leave the last talk with Dr. Nirmal. It's the most challenging and difficult thing to do and the most difficult clinical decision to make. And Dr. Nirmal, who has committed his life to uro-oncology, will be talking on this. He's professor and head of unit. Yeah, Nirmal, over to you. Santosh, you can unshare yours. And
Hi, good evening, sir. Is my screen visible?
yeah, yes, it's full screen. Carry on.
Yeah, thank you. Respected seniors and dear colleagues, good evening. I've been tasked with addressing the management of extraretroperitoneal disease in the post-chemotherapy setting. Not the most exciting of topics, but a very important one, because almost a third of the patients with metastatic disease will have residual masses outside of the retroperitoneum, and it's imperative for the urologist to know how to deal with them to be able to guide multidisciplinary management. The most common site is usually the lung at around 70%. The good thing is that most of the sites are solitary, but what's concerning is the high rates of histologic discordance between the retroperitoneum and the extraretroperitoneal sites. It can be around 20 to 50%. However, if there's fibrosis or necrosis in the retroperitoneum, the concordance in the lung can be as high as 90%. So to better understand extraretroperitoneal disease, let's look at the two cases we managed in CMC recently. The first one is a 24-year-old male with a left testicular mixed germ cell tumor with teratoma in the primary. He had retroperitoneal and left supraclavicular lymphadenopathy. Post-chemo, his markers normalized. So he then underwent a post-chemo RPLND, and there was teratoma in his biopsy. Now, how do we deal with the 3 centimeter left supraclavicular lymph node? Now, the second is a similar case, but instead of the left supraclavicular node, He has a sub-centimeter residual solitary lung nodule. Post-chemo RPLND specimen shows only necrosis or fibrosis. So should we resect this lung nodule or not? Now we must remember that patients with extraretroperitoneal disease are more likely to be poor risk, more likely to have received second-line chemo, and more likely to have large retroperitoneal masses. More importantly, it's the pathology of these retroperitoneal masses that guides the management of any extraretroperitoneal disease. Now, in this study by Masterson, with mostly thoracic extraretroperitoneal disease, the concordance between the retroperitoneal and the extraretroperitoneal sites was good when it's fibrosis or necrosis at around 83%. But the concordance decreases to around 40% or less with teratoma and germ cell tumor. Also, as shown in the Kaplan-Meier curves to the right, having viable germ cell tumor or teratoma in the extraretroperitoneum is associated with significantly poor progression-free survivals. Now, this study compares patients with complete clinical, that is radiological response to chemotherapy who were observed to those who had some radiographic disease and was resected. So patients with resected disease showing complete pathological response did better than those who were observed. So lack of consolidative surgery was an independent predictor for relapse. Hence, for pulmonary and mediastinal mets, resect if feasible. The only situation where observation may be acceptable is when in the absence of teratoma in the retroperitoneum and if the residual masses are less than 1 centimeter. The discordance between bilateral lung lesions again supports resection when feasible. If not feasible, these masses must be kept under close observation and biopsied at the first instance of radiographic progression. For patients with liver mets, this study by Pietzak et al. Again supports consolidative surgery, as 21% of those with fibrosis and necrosis in the retroperitoneum can still have teratoma or germ cell tumor, active germ cell tumor in the liver. Now, brain mets, though rare, tend to have the highest rate of active germ cell tumor post-chemotherapy, and they're associated with a very poor survival. Surgery may be considered in cases with a persistent solitary metastasis, depending on the location of the metastasis. Now, consolidation RT is beneficial for patients relapsing with brain mets where surgery is not feasible. Now, rarely patients may actually present with just extraretroperitoneal disease without any evidence of disease in the retroperitoneum. In such situations, the presence of teratoma in the primary testicular tumor is predictive of a high rate of teratoma in the extraretroperitoneum. More importantly, even in the absence of teratoma in the testis, 56% of the patients were likely to harbor active germ cell tumor in the extraretroperitoneal sites, warranting surgical excision in all cases when feasible. Now, there have been many instances where surgeons have carried out simultaneous excision of the retroperitoneal and extraretroperitoneal disease. However, extraretroperitoneal disease is mostly seen in the setting of advanced retroperitoneal disease. Hence, a stage approach may be safer, though there's no good data advocating one approach over the other. Now, surgery should start with the location of the highest volume of residual disease, which is usually the retroperitoneum. The histopathology then steers the management. In cases of bilateral lung tumors, like I already mentioned, even though the discordance rates may be as high as 20%, the presence of necrosis on one side can occasionally preclude resection of the contralateral side in case of multiple tumors where resection may be challenging. Now, the 5-year overall survival of extraretroperitoneal disease has been reported to be around 79%, but differs with histology, ranging from about 85% for those with necrosis to around 50% for those with viable cancer. However, viable cancer in the liver and brain were associated with much poorer survival. When active germ cell tumor is found at the time of resection, 2 more cycles of adjuvant etoposide and cisplatin should be considered unless the patient has already received both primary and salvage chemotherapy. Now, have we found a biomarker that can guide the management of extraretroperitoneal disease? Now, a recent prospective multicentric study has shown that M371 test, which measures the serum levels of microRNA 371A3P, outperforms the classic markers of GCT. However, unfortunately, this isn't expressed by teratomas. So going back to our first case with the cervical lymph node enlargement, where teratoma was present in the retroperitoneum. This patient finally underwent a left cervical lymph node dissection, and his biopsy showed teratoma. The second gentleman with necrosis in the retroperitoneum and a solitary sub-centimeter pulmonary nodule was actually kept under observation, and the lesion remains stable at 4 years of follow-up. Now, in our own series of 73 patients who underwent post-chemo RPLNDs, 7 had undergone excision of the extraretroperitoneal disease. They were all staged and executed about 4 to 6 weeks after the RPLND. And our study showed a 71% concordance rate between the RPLND and the extraretroperitoneum, and only a 50% concordance between the primary testicular tumor pathology and extraperitoneal disease, hence reinforcing the need to resect these masses whenever feasible. So to conclude, the management of extraretroperitoneal disease is steered by pathological findings at the time of RPLND, with the presence of teratoma being the major predictor of resection. Pure extraretroperitoneal disease in the absence of residual disease in the retroperitoneum must be resected whenever feasible, irrespective of the presence of teratoma in the primary. Stage resection may be safer and allows for a review of retroperitoneal histopathology. And post-resection, 2 additional cycles of chemotherapy are given in the presence of active disease. Thank you.
Thank you, Nirmal, for making that very complex situation, dealing with it much more simpler with the presentation. So now we end with this. We just have 2 questions. One of them will be addressed during the questions with the panelists. The other one, Santosh Naga, can tell me what is the mortality cause after RPLND? It's about 0.2 to 0.4%, if I remember.
Yes, sir. Large
Yeah.
series have shown 0.2 to 0.48, so it's roughly 0.5%. But that's data from large series, and the cleavage window complication to be around 15 to 25%.
Cause for mortality?
It's right from post-operative thromboembolism, if it is post-operative, or intraoperatively can be blood loss or major organ injury, major vessel injury.
Okay, I thank the
Because
panelists for.
we had bleomycin toxicity as our major cause for death post RPLND on the 3rd day, like I think ARDS with bleomycin, pulmonary fibrosis. So that's why I was asking that question. Anyway, thank you very much.
Okay, thank all the presenters, and then we will go to the next part. We have a set of eminent panelists with us who have a vast experience. Till now, we were looking at a lot of pure evidence base, but we have a wealth of eminence of knowledge with the panelists here. And I will do first a rapid fire round with the panelists, and then we will do one case discussion. So can I ask Dr. Amlesh Seth, please put your microphone on. And okay, Dr. Ganesh Bakshi, can you put your microphone on? Okay.
On.
Yeah, thanks a lot. Can you tell us, you worked in Tata, and probably in India, if I look at I looked at some of the published data, and I can tell you, I think the maximum volume of work on RPLND is done by Tata Memorial. So can you tell us what is the status of doing primary RPLND in seminomas in Tata?
So we have actually not been doing, because the primary RPLND in early seminomas was not in the earlier guidelines, and the data is re-emerging. We had been doing earlier post-chemo seminomas more than 3 centimeters, those RPLNDs, and a couple of them used to be very difficult, a couple of them used to be easy. It used to depend on what is the picture in the post-chemotherapy scenario, in the CT scans basically. About early seminomas, as was shown in the presentation, those 3 phase 2 studies have got a good data right now, but still probably they also say that further studies are needed. And probably, as was mentioned in most of these presentations which we heard, a high volume centers or a high volume surgeon probably who would, spend the time and remove everything within the template is very important. It's not just about any approach, open lap or robotic. I think you should be dedicated enough to see the template before surgery, study the CT scan well, and do it properly. So we see good results if these things happen. And as you mentioned, somebody mentioned Joel Shenfield. I mean, he had told me 10 years back that he does it for 14 hours or say 16 hours at times in the most difficult ones. So that is the measure people should remember.
Okay, I come to another question. No, I have seen presentations from Tata where you have shown the extraperitoneal approach. Now, which patients you would like to do? Do you do it as a routine or just for conference presentations you have done, and where you
So
would like to do that?
my colleague Dr. Gagan had started that, and it was a very good method in selected patients. This is what we found. I think if every procedure has a learning, so extraperitoneal in which you might take incisions, try to lift up the peritoneum and reach almost half the abdomen. I mean, it's that way. Strip off the peritoneum very carefully. So at times, very small peritoneotomies can happen, which you are supposed to then, later on suture up. And these things can be done from both sides technically. So selected patients, small masses, we had started initially and it did really well in them. So the best advantage used to be probably early return of bowel, length of stay accordingly used to be less, and things used to be better. But again, very honestly, we used to see a spectrum of patients with retroperitoneal load at TMH, and the selected ones used to go for these procedures.
Okay, thank you, thank you. Now I call upon Dr. Amlesh Seth. So your presentation a few years back was there on mid-cycle tumor markers checking after 2 weeks. This also answers one of the questions that I asked, what is the timing for post-chemo tumor markers? Can you elaborate on that, sir? It's only tumor markers, or there are some medical oncologists who will even do the imaging after 2 cycles to see whether there's regression or progression and how much more to give.
I'm sorry, the audio is very poor.
Could you get the question or not?
No.
Okay. Serum tumor markers mid-cycle after 2 cycles. Your presentation on that and your views on that.
It was not exactly my presentation. It was mainly from the medical oncology team. And yes, by checking the fall of tumor markers, you come to know what is the likely response going to be. And in NSGCT, in most situations, we will actually complete the chemo and then only take up for surgery. Desperation RPLND, we have done a couple of cases, but that was, I would say, many years ago, or maybe almost 15 years or 20 years ago. And the result in one of the cases was not very good. After the surgery, he had a very rapid recurrence. Before he could go back to chemotherapy, he had viable disease in the retroperitoneum. And before he could go back to further chemotherapy, he had recurrences and he succumbed to those recurrences. So mid-cycle marker assessment is mainly to assess and mainly for finding out what is the direction in which the particular patient is going.
Okay, sir. Second is your present. We don't see much data on the quality of life in cancers and cancer survivorship.
No, can you be a little loud? I'm sorry.
Okay, no issues. I'll try to come closer to my thing.
There is some
quality
issue
of life. There's not much.
In the internet.
Quality of life. There's not much data, and you have a presentation of quality of life after treatment in testicular cancers.
Yes, the quality of life in terms of working otherwise is reasonably good. All the patients who live long, they have a good quality of life in the sense they are fully active, they go for their work, and practically each of them is well employed and doing full-time work. There's no restriction in the number of hours of work, etc., etc. Obviously, there are issues with ejaculation and further fertility, and that has to be handled. And fertility is definitely a major issue, and erectile dysfunction obviously is not the issue. The only issue in quality of life is fertility. But in rest of the issues, they don't have any restriction in their quality of life.
Thank you so much, sir. Dr. Sudhir, can you unmute your mic? The next question is for you,
Yes.
Dr. Sudhir. You boast of having the largest world series on post-chemotherapy retroperitoneal robotic dissections. And the published, I think, is 35 to 40 cases. I wonder how much it has reached now. And the question specific is, are you restricting some indications for robotic, or you are going everything robotic?
Now we have more than 50, I think 56 robotic, post-robotic RPLND, and we shared the data in one of the AUA presentation with the Indigal group when we shared around 42 cases a year before this AUA. Now coming to your question, that I will not offer post-chemo RPLND, robotic RPLND to all cases, but I'll not hesitate in offering the post-chemo robotic RPLND to the large tumor. The reason, like 6 centimeter tumor, 8 centimeter retroperitoneal lymph nodes can be removed easily, provided there is not much desmoplastic reaction. Everything depends on desmoplastic reaction. But I'll not offer the patient who has got 12, 14 centimeter big, large retroperitoneal load. I'll not do with that. So it's a selective group of the patient only will end up with the post-chemo robotic RPLND.
Okay, thank you. And then the second question is a bit related to it. I have seen the presentations that EAU made, which were very well this thing, but there was always a concern raised on the panels by the judges at that point also, that if you're not ligating the lumbar veins or you're not ligating the lumbar arteries, retrocaval tumor, are you able to take out fully, or you think because it is minimally invasive, you can lift up the IVC and get it with the robot and laparoscope better than open?
Yeah, traditionally Swiss roll technique, which was described, which I'm also doing when I was, I started doing RPLND when I came to Rajiv Gandhi Cancer Hospital. But later on with experience, you can remove all the retrocaval or retroaortic tumor without even ligating them or selectively ligating them. You can see my video on YouTube where I have lifted both IVC and aorta without even ligating all the the lumbar veins and artery. So it's possible. It's not that's not possible, and we have not seen reoccurrence so far in our cases. I think the data will tell you. We will be having more publications. I don't remember, maybe 1 or 2 patients. Maybe I don't remember actually, but there's not a concern thing that the recurrence will occur in these patients. They do very well.
Thank you very much. We'll be coming back with the case discussion to the panelists. Now, Dr. Ganesh, I think he's the wisest and the youngest of us all. And he had a passion for doing these surgeries for 8, 10, 12 hours when we were trainees. So, Dr. Ganesh, can you unmute your mic? And the question to you.
Santosh, thank you.
So, the question to you, sir, you have been observing this probably from Donahue's time to now. We are all children who have seen the later half only. What do you think has been the evolution as far as the surgical aspect is concerned in management of these surgical tumors, apart from robotic, which has come in? Has anything really changed?
Good question, Santosh. Thank you very much. I do my surgery open. RPLND is one operation I would do open. I'm not sure I have the skills. Even if I had the skills to do this robotically, I'm not sure whether I would do it open. And I would go with the views of Schoenfield because I have seen him operate in MSKCC, and it has to be a very meticulous operation. As he says, it's the first time. Even Donahue says the same thing. The first time, your only chance is the first time. So I would do all these procedures only open. And I'm amazed at how people have the skills today, and I salute them for having done all this by robotic and everything. And I think because of that, the goalpost is changing to taking away the role of chemotherapy and bringing in robotic. Maybe fair enough. Maybe fair enough because these guys are young. And if we can preserve their ejaculation without causing secondary cancers and other problems, so be it. I mean, I think we should accept technology, but at the same time, not take technology as the gold standard. It's very good, but I still feel that we are all the old timers, and I still feel that the open operation still gives me the best outcome. I don't do this either laparoscopically, so I can't talk about it robotically or lap. So you're asking a very biased. You're asking a question to a very biased individual. So that's the bottom line. So
But in general, what do you think has changed over 40 years? Let's forget the.
I think what has changed over 40 years, what has changed over the last so many years is the advent of chemotherapy and a lot of data saying that, yes, there is a role for chemotherapy. Those days, everything was radiation. If you looked at everything, it was just blasting the retroperitoneum, One side of the Atlantic was surgery. RPLND was never done in UK. It was all Royal Marsden was radiation. The RPLND saga came in from Donahue in Indianapolis. So, it came from there. And the technique of RPLND, and if people actually read the original articles, they will tell you by looking at the incision of the individual, Donahue was able to say whether this guy actually had a good RPLND at all. He said, no, this is what, and I think we must all go back to that. These are pundits and gurus who have set the standard, but goalposts certainly has shifted from maximally invasive surgery to minimally invasive surgery with the same outcomes. And if they can show us in large data that the same outcomes, fine. Because this is, as you said, it's a rare tumor. It's a rare tumor, and therefore you need to collect the information from many centers. One guy may be very good, and therefore his results may be very good. But when you compare it with everybody, Aam Aadmi type of data, then the results they falter. So that's the basic issue here, I think. But technology has to be accepted in its value.
Thank you very much, sir. Get back to Dr. Sudhir. Just that same question that I asked Dr. Ganesh Bakshi. For small volume seminoma disease, pre this thing, are you doing robotic RPLNDs on those?
No, we are actually do offer these patients three alternatives. One is active surveillance, second is single dose carboplate, and fourth, the other is radiotherapy and robotic RPLND. Patient do not agree for surgery somehow. And we do not actually push it with them because logistically, single dose carboplate is the best treatment for them and not very harmful.
Recurrence rate?
I have not seen yet in our patient.
Single dose carboplatin, you haven't done given full dose.
We have we have given, but I have not seen recurrence. We do give regularly single dose carboplate. Have not seen recurrence so far. If I see the recurrence, probably then I can convince them for either for RPLND or something else.
Santosh,
but I have not done.
Get the case very quickly on. So we have one interesting case to just put some message through, and can you put it? Share. It's a patient who had come. Can we have a full screen and slide? Santosh, you have to do it. Yeah.
Yes,
yeah.
Sir.
It's a patient who actually had a orchidectomy elsewhere, high inguinal orchidectomy, and the biopsy was seminoma. Can you run the slide?
Yes, sir.
The biopsy was seminoma, and then he didn't have any adjuvant treatment. Probably he had a high-risk disease, but he never took any adjuvant treatment and no imaging, nothing was there. And he came in a very sorry state with a big retroperitoneal mass and probably disease elsewhere also. So we go to CT, next slide. His markers were high with the LDH high and this beta HCG also high. And he had a biopsy-proved seminoma. And you can look at the extent of his disease. His abdomen is completely full with this mass, and it is extending suprahilar. It is going beyond the division of the aorta. So I think there is no doubt about the fact that he needs chemotherapy. So we go to the next slide. He had chemotherapy, and he had this chemotherapy. Actually, the medical oncologist didn't believe, and they wanted to biopsy. They did the biopsy, proved that was seminoma. And they planned for BEP after 3 cycles, had some interstitial lung disease and problems. So the last cycle was EP. And after that, go to the next slide. This is the CT which showed that massive mass reduced, patient was doing fine. And as per the protocol, no, after 6 weeks, we did, there's a big mass still left. So we did the FDG PET, and the FDG PET showed positive uptake. So now Dr. Sudhir, because I have always heard now everything is resectable. Everything is testicular cancer is resectable. What will you do? Dr. Sudhir.
I will, can you hear me?
Yeah, we can.
Actually, I will definitely make an attempt to remove it. Only
the
after
whole
opening
renal
the
vessels
patient.
on both sides are encased. Aorta is 360 degree encased. IVC is 3 degree encased. And it is not just infrahilar. It is suprahilar, infrahilar, everywhere.
Santosh, that's not a problem. When you start dissecting, they come out very, many times you are lucky, and when you are lucky, they come out. At least you prove that it is unresectable. Yeah, I know. At least you prove that it is unresectable. Otherwise, there is nothing for him. Either he goes for next set of chemotherapy, but I will definitely make an attempt to remove it.
Okay.
We so do see a lot of
supra mass. Will you try to sling the aorta somewhere near the crura on the top before you do this, or you will just go ahead? If you make holes, you will control it there.
See, there, I think Dr. Ganesh will be knowing, or maybe I have not heard him saying, but I know he would have heard from his teachers from Tata. You have to make an effort to injure the aorta in RPLND also.
Yeah.
No, so in case even if it gets injured, you can repair it. We have learned those vascular surgery in Vellore. After that, I'm regularly repairing, even with the robot. Not with this patient, I'll not do with the robot, but definitely I'll make an attempt, because 4 cycles have begun. His markers are, though AFP was normal right from the beginning. How was LDH and SCG?
LDH was raised, LDH was raised, beta SCG was raised, but post chemotherapy, all markers are normal.
Normal, so
it shows a SUV of 7.
Yeah, I will make an attempt. That depends.
Any difference, sir? Dr. Amlesh and Dr. Bakshi, both of you, one by one.
So it's not different. As I said sometime back, post chemo seminomas, they have sometimes 2 different pictures. So as sir just said, this has, that globular fleshy picture, unlike very, plaque-like pictures which keep on happening. This surgery is extremely difficult. We should pass it through the MDT, obviously. And then if surgery is indicated, like sir said, give a good try for this patient. You will yourself need to do vascular things, or for this surgery, maybe it will be useful if you have a vascular hand at your side.
Dr. Amlesh, any difference?
Look, we'll definitely talk to the medical oncologists, and if they say no for the chemo, we have to give a chance to the patient. The patient would be a young man, and so what one needs to do is one needs to look at the supraceliac aorta. One also needs to look at the inferior extent, whether one would be able to get the common iliac or external iliac. So then wherever one gets the plane, from there one has to begin, and then one has to go both up and down. The contraindications would be if there is an involvement of the portal structures, if there is an involvement of the superior mesenteric artery. So if these are safe and there is some space available in the supraceliac aorta and lower down, then one can begin from the cleaner area and progress both from above as well as down. And then we have done such cases along with the cardiac surgery team. We don't attempt these cases on our own. We definitely take the cardiac surgery team along with us. And fortunately, they are quite supportive right now. And but yes, it would be very. Normally the left renal vessels are a big problem, but in this case, hopefully the left renal vessels are safe. The left kidney looks away.
No, so both the artery are 360 degree encased, and not for 1 centimeter or half a centimeter. That whole length from the aorta till the hilum of the kidney On left side, the hilum is not that much involved. Maybe you have little bit fat in between, but the right side is right up to the hilum. On the left side also, it's very, very close into the renal hilum, this plaque.
I know it is a very difficult case. Very difficult case. I would say perhaps one of the most difficult cases that I have done is perhaps less than what this is. I have done difficult cases. I mean, I have
Do you
looked
think
at
in
CT
this case,
scans and
because
scratched my
you are
head
looking,
and thought whether I should go in or not. But when the biggest problem is, what do you tell the patient? You can't tell the patient to wait for your ultimate end. That is something which you can't tell to the patient, especially to a young man who otherwise has a good performance status and who is otherwise, reasonably healthy. So, but yes, I would look upon this as one of the most difficult cases, and involve the GI team, involve the cardiac surgery team, and then if I have full support and possibility of a replacement of IVC if in case it is required, I have not replaced the aorta. We have not needed to replace the aorta, and IVC part we have sacrificed, not replaced it, and one kidney we have sacrificed. But yes, this looks reasonably bad. I would be very, very
this surgery we
careful
cannot guarantee without a risk of mortality.
Very careful in taking up such a case.
So without mortality, I think you will all agree that we cannot guarantee doing this surgery with any risk of no mortality. There is definitely a risk of mortality here. Will you consider biopsy as a option before you go in?
Look, biopsy, even if you get a biopsy, that does not sample most of it. And whether look, this is unlikely to be fibrosis. There are cystic areas. So there is a high likelihood of this harboring teratomas. So if there are multiple teratomas, sometimes
pure seminoma.
That's a seminoma, sir.
2 times biopsy, pure seminoma.
I know it is seminoma, the biopsy, but I think that biopsy is fallacious. In seminoma, this type of if you look at the CT scan, I will call it a non-seminomatous germ cell tumor. Because such cystic lesions do not occur in seminoma. Seminoma, the lymph nodes would be more uniform. They'll not have such variable consistency. And the response to chemo would be reasonably good. And the likelihood of fibrosis
so his response volume-wise is more than 75%. His whole abdomen was completely full from top to bottom with only tumor. Bowel and liver, where it was, we could make out.
Write down your message, or I don't know why I am not getting your voice. I am getting rest of the voices very clear.
Sorry, I'm telling the tumor volume-wise shrinkage is more than 75%. Initially, his abdomen was full of only tumor from top to bottom. From epigastrium up to lower down, he had only tumor. Now he looks absolutely normal, and he's doing very well. So I'll tell you what happened.
Santosh, he had a beta HCG which was very high, 859.
High. So normally they will be treated as NSGCT from the chemotherapy.
It was not just high, to consider it a fully seminomatous. And it is known that when testicular seminomas are there, the retroperitoneal at times can be mixed. There is data for that.
Okay.
I will tend to think that maybe that histopathology is wrong. If we can get hold of the slides and the specimen, then I would definitely like to re-review it.
So specimen occipectomy was done elsewhere. Here only we sampled retroperitoneum.
Rather than seminoma.
The retroperitoneum, only a small area you can sample. You can take 2, 3, 4 pores, but it will not sample.
Santosh, why do you want biopsy? What is in your mind?
I'm just asking, sir. Because this has a mortality, because there is a potential risk of mortality which the patient may not accept. So we'll tell you that this patient did not accept risk of mortality and he was feeling very well. So we said that if you don't do anything, we have to keep under very close follow-up. SEMPET study, what we have seen is that this negative is fine, but the false positive is very high. That study, I think, is really wrong in this false positive value of 96%. Our own data very clearly shows the false positive is very high. True positives is low. So the positive predictive value of 96% that SEMPET has shown, we don't take. Anyway, we'll show you the follow-up imaging. Patient did not accept surgery and high-risk surgery. Give next slide. Next slide.
You
So
did
we kept him
biopsy.
under very close follow-up, and we said if anything increases, we will jump in to do surgery. Otherwise, with all the risk, otherwise we will follow you up. And this is now 4 years since we are following this patient up. This 22 image, this patient, this is the present. It keeps shrinking. It just keeps shrinking on each time. And this is the last CT a few years down.
Seminomas are known to shrink for up to a year.
This does
post-chemo.
occur. This does occur when you have sheet of the tissue along the vessels post chemotherapy. They are the one which traditionally do not require any surgery, either is seminoma or non-seminoma.
So our own thinking in this case was just that because this patient was negligent to treatment, his disease actually grew to such a massive extent pre-chemo that the shrinkage, though it was more than 75%, it still looked very alarming. And we have come to no harm. We have been observing this patient. Now he is sick of coming very frequently for follow-up.
Did you do PET scan also in follow-up?
Yeah, we have done. There's nothing there now.
So that uptake is gone.
Yeah.
So the uptake was SUV7.
SUV7 at the beginning when we started.
Yeah. So that's the point. Now studies have shown that post-chemo in seminoma, the response continues even after the chemo for up to a year. And like you said, the positive predictive value, for PET is so low that even with SUV7, maybe this patient didn't have viable tumor. So it's either fibrosis or viable tumor in seminoma. So this patient was lucky enough to have continued to respond to that chemotherapy received.
And his tumors and markers were normalized. Beta HCG, which was raised, and LDH, which was raised. They are the only two raised which had completely normalized. Had it not normalized, then it would have been entirely different story.
Yeah.
And he's been lucky. We won't say that this is something, but before we embark on a life-threatening surgery, I think it's the patient. So that was a message we wanted to give on the positive predictive value.
So
not
one more
being
point,
so
sir.
good of a PET CT.
One more point. These patients actually kept on follow-up, and if they show shrinkage, good. But if they show an increase in size, that's the time you repeat a PET, do a biopsy if possible, just to sample. I mean, there is sampling error, and then you can offer, salvage chemo or RT, and surgery if you're bold enough and you're dealing with this patient in a high volume center.
I think we are 1 hour and 45
So I
minutes.
think there's one small thing for this case. I mean, as Dr. Sudhir Rawal sir was saying, we should first remember the normal template or protocol of treating in seminomas, because this is one-off case and this seminar is for the PGs. So I don't think they should answer observation or anything in the exam. So let that be clear actually.
Okay.
Could I just put in
any comments, madam? Otherwise, we wind up. We are at.
Sir, can we ask Dr. Ganesh what he would have done?
Yeah, Dr. Ganesh, sir.
Sir,
if this guy had agreed to mortality, and we had to bite that bullet, then I would have had to prepare. I would second what Amlesh said. There are two contraindications for a massive RPLND of this nature, and that is involvement of the superior mesenteric artery and the porta. If any of those two are involved, then forget it. I mean, you're not here, God, to cure everybody. But if those are not involved, I have actually replaced aorta with a graft in one patient who had this problem in velour. But I would have gone also with the view that we may have had to do an auto transplant as an individual. If there was a renal artery and renal vein, at least on one side. If not on both sides, at least one kidney you protect. Okay, take it out, cool it, and keep it, albeit there's going to be an ATN. Alternatively, you might decide that because you're on the side that we're not going to do much more dissection below the iliacs, you can go ahead and do. I mean, this was a left-sided tumor, I think, when we started. So probably the right side would be a better kidney to do an auto transplant and keep that going. Do that as a possibility, and I think I would look at that possibility too in a patient like this, simply because of the experience we have had with this problem with vessels and all that in velour. So we are bold enough to do these operations at the same time. So if push came to a shove, then we would. But what you said today is a big learning experience, and sometimes I think the patient tells us a different story, and this is ideal for them. But if you push to the wall, then I would do this.
Sorry, Dr. Bakshi also wants to say something.
So just 2-3 things. I mean, there were excellent presentations actually. So really well done actually. So right from the presentation one, it was superb. So one or two points I wanted to say. Dr. Madhuri was talking about fluid management, and we had experienced many times at TMH as we were doing RPLNDs, there is no blood loss, but the fluid management is difficult. And there is one thing that there is a lot of third space losses which keep on happening as we cut and open up these lymphatics. So many times an anesthetist doesn't look into it. So whatever we suck, whatever goes, that one point is there. And honestly, we do keep a drain. We use a tube drain in open surgery, and in robotic RPLNDs, which I have done, I've always put a JP drain. Why I would say is whatever said and done, there is 10 to 15% of chylus or chyles which we have seen in the extensive series of the size we operate, and probably that can cause ileus. It can add on to the ileus. So chyle happens. I mean, chyle leak. It doesn't not happen. I don't know what Sudhir Rawal sir does, but we keep a drain.
We do keep a drain, and we did have chylus ascites in the beginning of our when we started operating with the robot. The reason was that we were not clipping the lymphatics as we do in open surgery. We always clip or ligate, and we soon realized that what is the reason. If you don't clip and ligate or put a ligature in the later on, you may have to sometime open the patient. And I had to do the open ligation of the lymphatics in 2 patients. They became cachectic, after giving all the conservative treatment. At that time, I realized that you must, on table, you can see those lymphatics when you give per-op butter through rice tube. You can easily see those lymphatics, but do not give octreotide before at least 72 hours before. Recently, I landed up in problem. This was a gynae case where there was a huge chylus ascites, and when I took him for ligating the lymphatic duct, before that patient has had octreotide for conservative treatment done by interventional radiologists. They put lipodol and all everything, but it didn't work. So you must stop octreotide if you are opening these patients. This is a practical tip. It's not written in the books, but sometime really you may have to ligate those lymphatics by open surgery.
So I think I need to thank everyone for this wonderful seminar webinar, especially Santosh for thinking of the topic and giving such a nice format to it. All the talks were just excellent, and I also have to thank all the speakers because I think they did an excellent job. Dr. Arun, Dr. Madhuri, Dr. Santosh, and all the panelists. Yeah, Dr. Nirmal also. And all the panelists who are our teachers and from whom we have to learn. And I think we'll have to continue learning because their pearls of wisdom do help us in life and difficult situations. So thanks again for this wonderful webinar, and good night, everyone.
Thank you and good night.
Thank
good
you.
night, sir.
Thank you very much,
Santosh.
Thank you.
Thank you so much, everybody.
Thank you.
Especially my department. Bye. Good night.
Bye-bye, Santosh.
Good night.
Thank you.
Good night. Bye-bye. Thanks, sir.
Thank
Good
you.
night.
Bye. Good night.